Center, serving more than 40,000 patients across the Quad City region and surrounding communities. He assumed the CEO role in March of 2010 after serving as Chief Operations Officer from 2007 to 2010, helping to guide the organizational growth and expansion of patient services. Please go on and take a look at his full bio inside the program. This is just a snippet and a snapshot of who he has been for our community. It is my esteemed pleasure to welcome a friend and a brother beloved in the work of taking care of folks that happen to be low income, low wealth, and low wage earning families. Would you help me to welcome Mr. Tom Bowman?
I appreciate the opportunity to be here today, Reverend Ford and Project Now for putting the conference together. A few disclaimers, I guess, I would throw out at the start here. Reverend Ford was kind enough to talk about me as an expert. I wouldn't say I'm an expert in what we're going to talk about today, which is primarily Medicaid work requirements and some of the impacts that will have. Mary put a much better title on this presentation than I could come up with. But I have been the CEO of Community Healthcare since 2010, and I've been with the organization since 2007, so kind of pre-Affordable Care Act and post-Affordable Care Act, and some of the things that were put into place with that Affordable Care Act when we looked across the country and what we thought was important at that time. It was, in my belief, healthcare is right for all, but everybody needs to be in the system and have access to regular and routine care. This is not going to be a statement of politics up here, and several of the speakers have kind of noted this. What I hope to convey today is that we are going to be seeing a fundamental change in how Medicaid and healthcare is accessed in this country. The One Big Beautiful Bill Act cuts $1 trillion out of healthcare spend over the next 10 years. You cannot cut $1 trillion from a program and not expect to see some major upheavals. The things that I will discuss today, work requirements is the first sort of domino to fall in some of those things, but I will tell you that it probably won't be the biggest or the most impactful. There's other cuts that are coming to hospital systems and state budgets, also included in that act, that will have an even greater impact. So my hope is that we talk about educating ourselves and educating the people that we serve, so that when these things start to impact our communities, we're not caught flat-footed. And so the previous speaker probably said it better than I ever could of some of the challenging decisions that will need to be made by families over the next several years. What I hope to do is sort of put some scale to that today, and that's what I will hope to talk about. Okay. I know I'm preaching to the choir here. Most people know how Medicaid works, but in case you don't, Medicaid is a partnership program. So it is not a state program or a federal program. It is a state and federal partner program. There are really two kind of segments of the Medicaid population. You have those that are below 100% of poverty, those that are disabled and have maybe have ongoing chronic disease, children, those types of things. Those are what we would call traditional Medicaid. A lot of times you'll hear many of our political leaders talk about what the program was intended to cover in the first place, and oftentimes this is the group of people that we're talking about, very low income individuals. This is a 50-50, not exactly 50-50 in every state, but about 50-50 split between what the state spends on that part of it through their taxing and whatever revenue raising that they go through, and what the federal government sends to the states to pay for the care for those folks, very low income or physically disabled. The other one is the expanded Medicaid. So when the Affordable Care Act was passed, they wanted states to bring more people into Medicaid because it is a human right that people should have access to care. And unfortunately, your coverage oftentimes determines what kind of care that you can access. And so more people with coverage creates more access and creates better health care overall in our communities. And so they incentivized states and they said if you expand up to 138% of the federal poverty guidelines, so that's somebody that's making, what is it, about $21,000 a year at the top end, or a family of four making about $44,000 a year. So if you made up to that much, you could still qualify for Medicaid. Whether you were a single person or you had a family, Medicaid was going to help pick up some costs if the state would expand. And so you saw that 37 states in this country did expand. Iowa was one of the first. Illinois was right near the top. And we expanded Medicaid so that we could bring more people into the system. We could offer greater access to care. We could build programs and organizations to serve those individuals and have them be financially stable. I can tell you from the health center perspective, the FQ, CHC that I work with, it was dark times before the Affordable Care Act was passed. We were 35 to 36% of the patients that we served were uninsured. Yes. And you did not see grant at the federal level or state level keeping up with the demand for those patients to access care. The Affordable Care Act fundamentally changed what we were able to do. When I joined CHC in 2007, we were seeing about 25,000 patients in the Quad Cities. I know that Reverend Ford read the bio there. We actually crossed 50,000 patients last year. And so when you think about that, it's more than, 1 in 9 of your friends and neighbors that live in the Quad City areas come to CHC to receive their care. We would not have been able to do that if we hadn't expanded these programs. And so just to give you an idea of what is it we're talking about today, the second half there, the expanded Medicaid, when we talk about Medicaid work requirements, that's the population that we will most likely will be at risk of losing their Medicaid coverage. So wanted to set the scale. So what are work requirements going to be? So we've talked a lot about cuts to the Medicaid program, and you'll hear again a lot of elected officials, they didn't cut anything. We're not cutting Medicaid. We're only making sure that if you want Medicaid, that you work for it, or that you volunteer for it, or that you go to school so that you can get it. And so regardless of whether or not you believe healthcare is a right or healthcare should be a meritocracy to receive coverage, this is the bill that was passed. And so the work requirements will require those that are in that expanded Medicaid segment that I talked about, you will have to work at least 80 hours a month, which doesn't sound like a lot, but it is. And so even that part of it is not really a big issue, as Dwight mentioned. When every study that has looked at the Medicaid program, and especially at this expansion population, because there is income there, almost 95% of those folks that are included in the expansion section are already working.
That's right.
I mean, people are already working. So this idea that we're going to cut because people aren't working, we're going to institute work requirements to double check that people are working is, I don't know, seems absurd. Yeah. But that's the population. So we have examples of how this impacts. So if you want to get the savings out of the program that you're expecting because you have set your budgets to cut $1 trillion over 10 years, you're still going to need to get people to be less reliant on the Medicaid system. And so when you introduce work requirements, it's not really about verifying income or verifying work status or volunteer status. It's another step to maintaining coverage, and hopefully you deter people from taking that step, or you make it more administratively burdensome so that they give up, and then they are no longer in your Medicaid program. I can tell you both Iowa and Illinois, this program takes effect on January 1 of this coming year. Neither state has any system in place currently today to actually collect, analyze, and make these determinations on whether or not people still can stay enrolled in the program. And so that will be one of the takeaways today that we need to talk about. If we don't know how to educate our people, how are we going to keep them enrolled? Or if they don't know how to do it themselves. So things that we can think about. So 2 states have already implemented Medicaid work requirements, Arkansas and Georgia. In both cases, what you saw was, in Georgia, for instance, almost 73% of their Medicaid population lost their coverage because they couldn't do the requirements correctly, the state couldn't process them, or perhaps they were not working. That is also a possibility. I wouldn't say that it isn't, but it wasn't because they shouldn't have coverage. The vast majority of those individuals were working. It was the administrative burden that caused them to lose their coverage. And so then, based on those 2 states, we're able to get some estimates that I'll go over here in a second. And I'm sorry, on this next slide, you probably won't be able to see it, but there is, a lot of times when our elected officials are talking about Medicaid, they make it sound more like EBT or welfare, or some sort of a check is coming to this individual person. They're living off of Medicaid, so to speak. That's not how Medicaid works. And so when you think about the broader impacts on the community, on budgets and so forth, which I'll illustrate, you got to understand how the Medicaid spend works. Medicaid gets state and federal dollars. Those dollars go to clinics, they go to hospitals, they go to pharmacies, they go to physical therapists, they go to anybody that takes Medicaid, being a service provider. Okay, the patient never sees those things. The patient gets the access to the care that they need, but they don't have to worry about the billing part. That goes to the provider. And so what do the providers do with those dollars? And we're talking about velocity. How do we get those dollars into our community? Why did we expand Medicaid in the first place? It was to bring more money into our community so that we can expand access to care. And so when those dollars come to those healthcare providers, it goes to my doctors, my nurses, my dentists, my pharmacists, all those people that work in my organization, my accountants, my billing people, my front desk staff, my community health workers. They in turn go out and buy goods and services in the community, and they end up paying taxes to their state and local communities. As well, as an organization, I'm buying supplies from the dental supplier, I'm buying drugs from drug manufacturers, I'm buying gowns, I'm buying all the things that we need for our business to run. We're supporting local businesses that we work with to supply us and partner with us. They in turn go through that same cycle, paying their employees and so on and so forth, and that money cycles directly into our local economy. And so this idea that we're going to cut without any harm, because we're going to save in a state budget line or a federal budget line, you're going to see that impact at the local level, and we need to start to plan for what that impact is going to be. So what is that impact looking like? So again, small slides. I should have had somebody put these together that knows how to project correctly. But, so I know this is really hard to read. These charts were based on this. You can go out and find it. It's from the Commonwealth Fund. They used the experience in Arkansas and Georgia when they did work requirements to estimate with the similar results, what would the impacts be for every different state, okay? And so in this one, we're looking at a couple different things. GDP, state GDP loss. So GDP loss for Illinois is going to be estimated to be about $2 billion a year for the next 10 years. Iowa, about $300 million a year. That's state-based GDP. The Quad Cities is a pretty big part of the GDP in the state of Iowa. That GDP loss is going to affect our community. State and local taxes. In Illinois, you're going to lose somewhere between 150 and 215 million in state and local taxes. State and local taxes help fund city budgets, county budgets. How many of us have grants from, not necessarily federal, but from state, county, city level grants and or other types of supports? The pressure is going to be immense on those programs. In Iowa, you're talking $15 to $21 million, again, annually for the next 10 years. How do you maintain your services and so forth when you're seeing those kind of cuts? Those are things that we need to start thinking about as a community. Job losses. So in Iowa, they're estimating somewhere like 13,000 to 18,000 jobs will be lost, about half of those being healthcare. or in Illinois, 13 to 18,000. In Iowa, it's between 2,100 and 3,000. Again, half of that is in the healthcare space because we're the ones that typically get paid by the Medicaid, but it's all those other things that we buy from suppliers and others in our community. So it has a ripple effect or a velocity effect, compounding. So when we talk about this, again, it's not necessarily whether or not we agree with the program or agree with the policy change. It's more like, how are we going to wrap our heads around this as a community and a group of service providers that still, our patients and our clients are going to have needs, but we're going to have fewer resources in order to deliver on those needs. There's just no other way to look at it. So boo-hoo for us, right? But it's the patients, it's the parents, it's the others that we're all most worried about. You know, many of us will still go home and come back to work tomorrow and keep working at it. But what are the downstream effects and the ripple effects? Again, I can't probably say it any better than the previous commenter, but so what we see is when you lose that health insurance and you're on a budget of, not a budget, but let's say you make $21,000 a year, that's before taxes and everything else are taken out, and you're trying to come up with your budget for the month, and you now no longer have Medicaid, you kind of have two options. What are the other ways that you could be insured? One, you can get it through your employer. Well, if you're $21,000 a year, you're likely making below, you're making about $7.50 an hour or whatever it is, or $10.40 an hour. Many of those jobs are either part-time or they don't have benefits associated with them. So you're not going to buy the insurance through your employer. Okay, well, let's go out to the marketplace and maybe we can buy insurance through the marketplace. Most of the patients that are at that income level will still get access to discounted coverage, but when I go in and I see, even with the ACA discounts that are still in place for me, I still have a $200 a month premium that I didn't have before because Medicaid was covering my healthcare expenses. Where's the $200 come from? I have child care expenses, I have rent expenses, I have food expenses, utilities, all those things. Every time we take a little bit out of that bucket, it tips over, and there just isn't enough left. And so the idea that we're going to go out and have a bunch of people purchase insurance through their employer or through the marketplace plan is not a solution. Okay, so what ends up happening? Even if they don't have insurance. So our country is good in a lot of ways. You can still go to the emergency department if you need health care coverage. You can come to an organization like CHC. There aren't enough of us out there, but in our community, we're going to put a sliding fee in place for you, and we are going to deliver primary medical, dental, and behavioral health care. We're going to do everything we possibly can to make that care affordable, and we're going to slide those fees for you. But that's not going to help everybody that may not be able to access CHC. And even then, there's some things that we can't cover. So let's say you're a patient with chronic disease, and it's not enough to maintain your coverage in the Medicaid program, but you still need medications to manage that disease. You might need to see a specialist once in a while. CHC doesn't cover the cost of your specialty care or discount the cost of specialty care. Or, worse yet, you end up in the emergency department. The lowest end emergency visit, and this is for a minor thing, maybe you have a sore throat or runny nose or headache, fever, something like that, and you decide to go to the emergency department because it's after hours and CHC is closed. If we're open, you should come to us first. I'll put our plug out there. But let's say you end up in the emergency department, minimum is going to be $500. Minimum. For a moderate level emergency department visit, $2,500. You now no longer have Medicaid to pick up that bill. And so where does that come from? I don't have the answer, unfortunately, but it has to come from probably most of the groups in this room banding together and trying to figure out how we're going to still deliver, care and support for those individuals that have lost their insurance coverage. And so this is a great illustration. It shows that when healthcare no longer comes from the Medicaid program, it has to come from somewhere else. And unfortunately, we see that all too often in our patients that we serve. 90% of who CHC serves is below 90 or is below 200% of federal poverty guidelines. These are real choices our patients are making every day, whether they're cutting their bills in half to extend them longer, even though we can, help them with that, or they skip a few visits because they just can't afford that $25 out of pocket even. This becomes harder in the long run. So, I guess I want to close with what can we do? And it is not different than a lot of things that we've heard when we're talking about trying to end homelessness, or we're trying to work on recidivism and clean slate programs and that kind of stuff. Number one thing I think that we should be focused on is contacting local lawmakers. I wish more of them were here today. I appreciate any of them that are here today to hear about some of these challenges. But where we need to start is our voice has to be heard. You have to call, run into, go to when they're having legislative forums, and talk to your lawmakers. The first thing I would be asking each one, and that is what I'm asking each one, is are they pushing on their administration at the state level to clarify what is going to need to happen for our patients to maintain their coverage? How are you going to collect this data? How often do they have to submit? What is the phone number they need to submit on? What is the website? What does the form look like? Because all of that is going to be really important to making sure if you qualify, you should be covered. There's no reason that we have to let somebody go without coverage if they qualify. We can assist them with that to take out that administrative burden. So asking lawmakers to pressure state administrations to get those rules out and get the process out, I think is a big part of it. Thinking about in your organizations, how are you going to notify your patients about some of these Medicaid changes that are coming? How are you going to educate them? At CHC, we are talking about how can we put in automated messaging to go out through the patient portal, reminders when their insurance is, or when their Medicaid is set to expire, trainings in-house, access to computers in-house, about anything that we can do to help those patients maintain their coverage, we are going to try to do, but we can't do it all, and we don't see everybody. So can we prepare our organizations to be helpful in that fight? And I would ask you all to consider doing that within your organizations. And finally, I think looking at philanthropic opportunities here in our community, I think educating, if you guys sit on boards or you talk to, I see Linda here, so I'm going to pick on her. You can talk to Linda Watson. She'd probably give you a list of all the different philanthropic organizations. How are we educating them about what the need is that is coming? Because it's going to be large. Certainly, we each have an individual responsibility to do our part, but also how are we leveraging our relationships and regulating or leveraging our partnerships so that we can amplify our voice. And so I would ask that y'all, if you haven't been on top of this topic, I would ask you to go out and read about it. There's a number of different studies. There was a RAND study that came out last week and used a lot of different data and kind of came to the same general results as the Commonwealth study. As I look at this, and I try not to be alarmist, but it looks like a tsunami is coming this way and we're not ready. And so I would just ask everybody, if you have questions, concerns, or you want to talk more about it, I'm again not an expert, but I know enough to be dangerous on this and certainly can connect people to more information about this topic, but would appreciate your support in educating and advocating for our patients that we serve, or the clients in your organizations, or somebody that you care about that may be affected by this policy change. So thank you guys very much.
Thank you. We want to thank Tom again for a great presentation. Although he very graciously says he's not an expert, there are very few people in community that work with a population that is below the poverty level, that have not had as much experience, as much data, engagement, and 51% of his board of directors are from the people he served. This is what leadership looks like. We appreciate you and thank you and your team so very much. All right, so
Now, you've been sitting just for a moment. You've had a great meal. You have, of course, buckled up pretty good. You kept arms and hands inside. What I'm going to do is ask that we take a 10-minute break.